having said all these things about the thyroid, I want to go over a couple of cases with you and see to make sure that everybody understands what we've talked about. So thyroid case number 1, a 27-year-old woman comes to your office for throat pain for 1 week and palpitations. So she's got throat pain and 1 week of palpitations. She has no prior history. She takes no medications. The blood pressure is 142/92, so it's a little bit elevated. The pulse is 112, it's elevated. The oropharynx is normal. The thyroid is painful and diffusely enlarged, so it's painful, but it's diffusely enlarged, so you question the diagnosis here. You don't know what's going on. The TSH is low. The free T4 is 14. This is elevated. So I'm telling you, this is usually the free T4. The upper limits are normal anywhere from 5 to 7. So this is elevated here. This is low right here. Less than 0.1. It's low. This is elevated right here, the free T4. And your radioactive iodine uptake scan is low. 3% is low. So what would be the next most appropriate test if you wanted to confirm the diagnosis? And you've already pretty much confirmed the diagnosis here. And the answer is, if you wanted to get one more test to show what this patient has, you may get an erythrocyte sedimentation rate to show that this is an acute inflammatory state, because what this person has is subacute thyroiditis. But the most appropriate next step here would be to treat the patient. If they ask you what's the next step, treat the patient with what? Pain medication, nonsteroidals, aspirin, and stuff like that. The test, if they're asking for a test, it's usually the erythrocyte sedimentation rate, to show that this patient has intense inflammation. But most people don't even have to do that. Once the radioactive iodine scan is low, that confirms the diagnosis of subacute thyroiditis. Again, this is a disease that goes away after a couple of weeks, some months or so, so you don't have to treat it with antithyroid medication. Be careful of that. Only symptomatic treatment. The next case, a 32-year-old man is admitted to the ICU, to the intensive care unit with delirium, is treated for presumed sepsis. Thyroid hormones drawn on the day of admission show a very low free T3. The TSH is normal. There is concern about myxedema coma given that he had a history of a thyroid nodule. Now, what did I tell you? What's the first test we look at when we're suspecting thyroid disease? We look at the TSH, and if the TSH is normal, I told you that this patient has euthyroid, doesn't have any thyroid problem. Now you're going to ask me, why does this patient then have a very low free T3? And what this patient has is this thing called euthyroid sick syndrome. Euthyroid sick syndrome is a very interesting syndrome that occurs in people that are very sick. They have presumed sepsis or they have multi-organ failure. We usually see it in patients in the intensive care unit. Now, these patients are not the typical patient. You shouldn't be drawing free T4s and TSHs in these patients and free T3s. Because if they have myxedema coma, your TSH is going to be off the wall. It's going to be very high. That's going to be diagnostic. So you shouldn't be worrying about things like that in this patient. But this patient has this thing called euthyroid sick syndrome, and it seems that patients that have multi-organ failure, that have sepsis, develop a catabolic state. Basically, they shut down their metabolism to kind of conserve energy. That's the theory. So what they do is they suppress the conversion of T4 to T3. So your free T3 is very low, but the TSH is normal. So this patient, right away, from what we've said before, is euthyroid. Please be careful of this case, that they don't give it to you on the boards. This patient is euthyroid. You don't do anything about their thyroid function. You don't give them thyroid hormones. They've done studies in these patients, and they've given thyroid hormones, and it hasn't changed prognosis or outcomes or anything like that. This is a normal phenomenon. So you basically don't do anything to this patient. You shouldn't be checking thyroid hormones in such patients. Case 3, a 57-year-old woman comes to your office for fatigue and palpitations for 1 month. She has a history of a goiter. She takes no medications. Her blood pressure is 142/92. It's a little bit elevated. Her pulse is 97. It's elevated and irregular. In fact, it's irregularly irregular. There are 2 large nodules in the left thyroid lobe. No proptosis is noted. What is the most likely diagnosis here? So from what we've said, you should know that the older people that come in with palpitations, right? She has a history of a goiter, right, before that was non-functional. Now she comes in with symptoms, some symptoms of hyperthyroidism, and she probably has atrial fibrillation, and you find 2 large nodules, no proptosis, so it's likely not Graves' disease. This patient likely has multinodular toxic goiter, toxic multinodular goiter. Remember, it occurs in older people. It presents mostly with cardiac manifestations. Number 3, these patients have a history of an old goiter that was non-functional, and now all of a sudden, for reasons unknown, it becomes a toxic goiter, becomes a functional goiter. So this patient has toxic nodular goiter, and you treat it exactly like Graves' disease. Be careful, because these patients, as I said, they don't have all the typical manifestations of hyperthyroidism, and they present mostly with cardiac manifestations more than anything else. Case number 4, a 24-year-old medical student comes to your office for weight loss, 15 pounds over the last month, and palpitations. She takes no medications. She reports no constitutional symptoms. The blood pressure is 142/92. Her pulse is elevated 94. The thyroid is normal. You don't find anything wrong with the thyroid. You can't palpate it well. There's no evidence of proptosis. Fine tremor is noted. The TSH is very low here. The free T4 is elevated. And look at this, the radioactive iodine uptake scan is low here. So this patient has hyperthyroidism, but you notice some very interesting things about her. She doesn't have proptosis. You can't feel the thyroid, so she doesn't have toxic nodular goiter, and she doesn't seem to have Graves' disease. And you confirm this by the radioactive iodine uptake scan, which is low. You know, it doesn't seem that she's got a subacute thyroiditis, because she doesn't have a painful thyroid either. So the next most appropriate test in this patient would be a thyroglobulin level, because you're concerned about factitious thyroiditis, that she's taking this either to lose weight or for other psychological reasons, that she's taking exogenous thyroid hormones. Some patients, when they're taking weight-losing medications, and they get it online or they get it from different countries, contain thyroid medication within the stuff that they're taking, and they don't even know about it. So sometimes they tell you, I didn't take anything, you know, I don't think I took anything. They're right sometimes. They don't know what they're taking. They're just taking some powder somebody gave them to lose weight that came from another country, and they have thyroid medication within this prescription. So the next appropriate test here would be thyroglobulin. If this is exogenous, the thyroglobulin levels here would be low despite the elevated free T4. So this would tell you that this is exogenous thyroid hormone. It's not endogenous. If this were endogenous, both the FT4, the free T4, and the thyroglobulin levels would be elevated both at the same time. Case number 5. A 32-year-old woman comes to your office for weight loss, about 12 pounds over 1 month, palpitations, and generalized weakness. She takes no medications. She reports no constitutional symptoms. Her blood pressure is probably okay. Her pulse is 104. It's elevated. Her thyroid now is diffusely enlarged. So sometimes, you know, in this kind of thyroid, you could put your stethoscope over it and you could hear bruit. You could hear bruit because it's so vascular. The proptosis is evident, and fine tremor is noted. So right away, without me saying anything more, just by seeing the proptosis here and the thyroid exam, you know the diagnosis. This patient has Graves' disease, right? There's nothing else that this could be. So the TSH is low, the free T4 is elevated, and the radioactive iodine uptake scan is very high. So it's high. 85% is high 24 hours because top limits and normal is about 40%. Now you don't have to know that by heart. They'll give it to you that if they give you a radioactive iodine scan, they'll give you these parameters on the boards. But this is high, so she has a free T4 that's elevated. She has hyperthyroidism. It's primary hyperthyroidism. And the radioactive iodine uptake scan is high, which tells me that this patient has, and it's diffusely increased, so this patient likely has Graves' disease. That's my diagnosis. So they ask us here, what would be the next most appropriate test in this case, right? So there's not a lot of tests that you could do further, right, in this case, but they ask for a test and they say, okay, I want you to document that this patient has Graves' disease 100%. Then the next test would be the thyroid stimulating immunoglobulins. I said we don't do it in everybody, but if they ask you, this is what they're looking for. They're looking at to confirm the diagnosis, and you do the thyroid stimulating immunoglobulins. Now, a more appropriate answer, more appropriate question here would be, what would be the next most appropriate step in this case? And the most appropriate step in this case would be to treat the hyperthyroidism here, right? To treat the hyperthyroidism, basically to give the patient beta blockers, a combination of beta blockers and anti-thyroid medications at the same time to suppress, or what is called cool down, the thyroid before you go into the definitive treatment, the long-term definitive treatment, which is the radioactive iodine ablation. So that's the way you work these patients up with Graves' disease.